All right, here we are on another episode of Live with Dr. Kazi. You are a population health expert, co-founder of DoctusTech, and today we're going to do a bit of a deep dive into the recent case of the Department of Justice and whistleblower Kathy Ormsby against Sutter Health and affiliates with their False Claims Act violations alleged and the $90 million settlement. So my first question to you is, just right off the hip, what is the first thing you think when you hear about that case?
I think a lot of us providers know that there's a lot of pressure around documentation accuracy, and it felt like it was a Swiss cheese effect. I have to think that my colleagues in the field of value-based care are trying to do everything right, always trying to be accurate and document appropriately. But sometimes when you set up systems in piecemeal, there's not a proper safety net to catch when multiple errors happen the perfect way. And unfortunately, that was what the situation looks like it could have been at Sutter Health.
I mean, in the big 45-page piece that the DOJ released, there were a lot of different parts that got highlighted. And I think we were discussing earlier, some of the things that they did make perfect sense. Like, that's a good idea, right?
Yeah, that's right. You want to bring in your patients once a year, talk about the medical conditions, talk about what's happening, make sure that everything's safe at home, really try to plan ahead for the following year. So the concept around an annual wellness visit is completely kosher. It's actually encouraged and something that us providers look forward to doing. And oftentimes during those visits, you will document HCC diagnoses. These are things that the patients have. You want to talk about it with the patients, tell the plans, tell the Medicare, talk about what their medical conditions are, and also think about what you're going to do preventatively for that following year. And during that visit, you'll often document HCC diagnoses. And sometimes programs will provide providers with all the information possible so they can properly document during that visit. But what you want to do is be careful that you're not helping increase the up documentation or up coding and making sure on the back end everything is compliant. And sometimes if you're just focusing on the documentation part and making sure the diagnoses are in the chart before claims is submitted and not thinking about the compliance piece, that's kind of where you can end up in Sutter situation.
Now, one thing I read that it came out, they set a goal to increase their risk adjustment scores by 28%. It seems a little high.
Yeah, nationally, the average is around 3% when you think about risk adjustment going up every year. And so typically, what we never try to tell providers is we have a target on which we want to increase the RAF. It's more about how do we improve our accuracy. So thinking about both up and down. So if you're have diagnoses that you're carrying over that are inaccurate, really trying to empower your providers to say, hey, this should not be submitted or this is inaccurate is the right way to think about it. So setting a goal of 28%, again, not having been in their shoes, perhaps was more around increasing their accuracy and not necessarily increasing their score, which would be a no-no.
And how do you feel about a coder coming in after the encounter and adding a few codes that the clinician may have just simply overlooked?
Yeah, what Sutter had in place is no different than multiple groups across the United States. They have work being done before the patient visit. They have work being done after the patient visit. Coders are an integral part of the team to accurately reflect the work that us providers are doing with patients. And the problem becomes when you're suggesting diagnoses to providers who have not necessarily been educated around why that's being presented in front of them and given them a workflow that allows them to only check boxes to carry diagnoses over so they can get through the workday. The key really here is, are you giving the right information, educating the providers, and allowing them to make a clinical decision? So when you have a coder coming in and suggesting something that wasn't necessarily documented at the point of care, it becomes a little bit more of a gray area. And you want to be very clear that your provider understands why they're being suggested that diagnosis, and then given the power to say yes or no in either direction.
We talk about the risk. We talk about a lot of risk adjustment, but the risk to providers that this case seems to indicate is that not just CMS, but also the DOJ is very concerned with the first time I've ever seen the word mischarging. Talk about the risk to provider groups now.
Yeah, this is a whistleblower case, right? So we know that the reason that the DOJ looked at this was because someone raised their arms and said, hey, this doesn't feel right. RADV audits are another way to prevent abuse of the Medicare Advantage documentation and compliance programs. But that right now is focused just on payers. Every time we talk to provider groups or I speak with a colleague, I'm always trying to encourage them to think about compliance more than RAF accuracy, because it's only a matter of time with the direct Medicare contracting model, ACOs taking downside risk, that us provider groups who are taking on this risk are going to be held accountable in the same way that a payer is. And so it's unfair for us to say, look, we submitted a clinical diagnosis without justification. It's up to the plan to figure out whether we are compliant or not. And then we're shielded by the plan. So right now, all audits through MAs plans are happening at the payer level, but I'm really confident it's only a matter of time before it starts coming back to us provider groups. So this, if nothing else, should make people a little nervous. Do they have the right processes in place? Are you educating your providers to understand the why around risk adjustment? Am I accurately documenting? Do I have the right justification? And am I given the right amount of time to say yes or no to these diagnoses? If you don't have the right information, you should not be carrying over any diagnosis that is just a yes, because it's going to make your boss happy or make you get through the day easier. So making sure that conversation is happening is integral to making sure that the next piece, which is compliance, is happening.
So as we kind of peer over the garden wall here into Sutter Health's dealings, obviously no admission of wrongdoing was made in a $90 million settlement. But from out here, what do you see that they could have or should have done differently or better?
Yeah, I think if you think about risk adjustment strategies and you think about it in a pyramid, the foundation on which you build risk adjustment should really be around empowering, educating, and giving knowledge transfer to providers so that they can make clinical decisions. So what is it that they're doing? Why are they doing it? And then what should they do if they see a mistake? And so if that foundation was built, I suspect that the providers would be able to stand up and say, hey, some of these diagnoses that you're putting in front of me are inaccurate. And a big mistake that was seen not only at Sutter, that I see across the United States, is acute diagnoses are being carried over year, meaning things like acute stroke, acute heart attack, that should not be coded in a patient the next year, or malignancy that's been resolved and again being carried over because someone gave a fax paper or a piece of paper to a doctor and said, can you please check yes or no to these diagnoses? And maybe the provider thought, hey, the patient did have this at some point, but didn't realize that this is not something that happened this year. And that's up to, again, building the knowledge around what you're trying to do, putting the infrastructure in place so that you're catching it and saying, look, an acute diagnosis carried over year. Let's go back to this provider. Did this patient really have 2 strokes, 2 consecutive years? Maybe it's yes, maybe it's no, but there needs to be a process around catching that. So I think building knowledge, having a point of care workflow to empower your docs, and then really building a solid foundation around compliance is going to be key.
That's good. I like that. One thing that we saw in this specific case is they were accused of intentionally coding unsupported diagnoses and then finding them and not paying back on purpose. So when we talk about increasing accuracy, talk to me a little bit about the process of, I guess, how you run a business looking at money you've gotten and how to give that back in a way that's ethical and reasonable.
Yeah, I mean, it's really hard to give money back once you've gotten it. So the best approach is really don't take the money if you're not deserving of it. So really making sure that before any diagnoses go to claims and then go to the payers and then Medicare, you know with full confidence that they actually existed in the patient chart. So one thing I always coach and work with provider groups is saying, what are the diagnoses that are acute you don't want to carry over, and make sure that's a no-no. But the second piece is, let's talk a little bit about at the point of care, as the doctor's writing the note, is there a way to catch and make sure that there's compliance there before you even submit the bill? And if not, let's make sure we're doing some audits and charts to give some confidence to you as an organization that you're not receiving any reimbursements for diagnoses that are inaccurate. And then the second piece to that is, once you've done that, is having a retrospective aspect of, let's do some chart audits, let's look through this and make sure we're paying back appropriately, because compounded over time, that can be a massive bill as well.
Okay, so as we look into the future here, I mean, the whistleblower case is one avenue. The RADV audits are another avenue. But I guess what is the risk level for a doctor? Like, what's the likelihood of getting caught at this point?
Yeah, and it's, is something morally wrong only if you get caught, right? We could talk about that forever. But to me, it's a question of do the right thing the first time around. I think all providers have gone into the field because of that same same level of commitment to their patients. So if you are in value-based care because you care about delivering better care and you think you can do it at a lower cost, risk adjustment is a necessary part of that. But do it right the first time. So document accurately. And I think that the two pieces that provider groups should be worried about is there's a significant risk to them that Medicare is going to now start to audit provider groups as the risk is passed from payers to provider groups. And the two things that I see all the time that providers are doing incorrectly is one, they're carrying over acute diagnoses. And two, when they're putting the diagnoses in there, they're not necessarily justifying it. They're being told by their group that, hey, these diagnoses might exist. Do you agree? And in order to move through the day, they say yes. But the diagnosis maybe technically doesn't meet Medicare or doesn't meet clinical guidelines. And that is not being audited right now. And I don't think that's going to be very far off from when Medicare says, not only do you have to be compliant from a technical perspective in the pieces of your documentation, but hey, the definition of the medical problem needs to be there. Does the patient really actually have that diagnosis?
The white paper on RADV audits, but the principles from that should be just as applicable to provider groups. And I want to just touch on those. One thing our paper determined was that provider behavior is the first thing to fix. And that's the education piece. The next thing we determined was that proper documentation fixes nearly everything. You mentioned that if you document something that isn't, maybe it was well documented, but it wasn't clinically accurate, that could spell trouble down the road. But right now, we just really need documentation to be on point. The next thing we've determined is that without the proper tools in place, documentation is nearly impossible to get right. Another thing, we did determine that certain codes get used erroneously more than others. That's also a very large, terrifying gun to the head of a business. Is there anything I missed? Any big takeaways we want to make sure we're sharing?
No, I think the whole process of auditing and checking is all limited by human capital, right? We don't have enough hours in the day or people to help us check this. But as we enter into this next digital era of healthcare, where we're in the midst of, technology can help you do that. And not only can you audit some sample size, but you can have good visibility to your entire patient chart and be able to say with full degree of confidence that every chart that I'm documenting against has some type of technology or eye that's been placed on it to make sure I'm compliant and making sure I'm not making a human error, which happens. So utilizing technology to solve for some of the workflow gaps, to solve for some of the knowledge gaps, will augment, not necessarily replace, the strategies that a good compliant organization has. So making sure you build that in and then having a clear safety net and allow people to be able to raise their hands if they feel uncomfortable will be the key to making sure you're compliant, and then have have good nights of sleep at the end because you're doing everything right for the right reasons.